Hi, welcome to Lecture 6, Types of Economic Evaluation, Making Sense of Cost, Outcomes, and Value in Healthcare Decisions. Why do we do economic evaluation? I think this has been covered earlier. Number one, we have limited resources but unlimited ones. Your budget is limited. There's a need to choose between competing options. Firstly, do we spend on healthcare in the first place, or do we spend on defense or education or whatever the country thinks is important? But having decided to spend on healthcare, how then do we spend on healthcare? What do we do? Do we focus on prevention? Do we focus on treatment? Do we focus on rehabilitation? Do we focus on diagnosis? What is the thing that we want to focus on? When we talk about economic evaluation, it's about cost versus benefit. As an AI advisor, one of the key things I'm supposed to do is look at return on investment on AI, artificial intelligence in healthcare. Is it really cost effective? Does it really give the benefits? Does the benefit outweigh the cost? All these things we covered today. The four main types of cost evaluation or economic evaluation you can look at is number one, cost minimization analysis. How do we minimize for the outcome that you choose? Cost effectiveness analysis, cost utility analysis, as well as cost benefit analysis. I'll go through in them briefly and then we'll go in depth in the subsequent lectures. Cost minimization analysis used when outcomes are the same, so you compare costs only. This is very simple, but in real life not so simple because not all outcomes are the same. Example, if you have two generic drugs with identical effect, it's a no-brainer to choose the cheaper one. But cost can be also in terms of delivery. For example, if the outcomes are the same, one is actually through oral and one is injection. Let's assume it's the same. You may still prefer to choose the oral one because it's more convenient and higher compliance. Doesn't necessarily mean if injection is cheaper, we recommend injection. Next, we talk about cost effectiveness analysis. This is something that we always use. Why we do this is because we need to define a certain outcome. For example, life years saved. Or in one of my study, I look at amputation. What is the cost to reduce one diabetes-related amputation? Why we do that is because we cannot easily monetize it in terms of cost, which will be covered in the next slide. We compare cost per unit of health outcomes that we want to achieve, whether is it to add years of healthy life, which is what the vision of National Healthcare Group. So, example, to compare two hypertension drugs, we look at something like, for example, MACE. We look at things like what are the major adverse cardiovascular events. So these are some things you can look at. How many AMI, myocardiac infarction that we prevented, how many stroke that we prevented, and so on. Cost utility analysis is it's like a cost effective analysis, but it focuses on QALYs, which is something that we kind of like standardize. Whether is it comparing between respiratory, cardiology, what else? That oncology. Let's compare in terms of quality adjusted life years. This is necessary because onco drugs do not prevent stroke. Hypertensive drug prevents stroke. If you don't have a standard metrics to compare, then you are not able to allow cost condition comparison. For example, in this case, it's cancer drug versus joint replacement. So cancer drug can prevent mortality, death. Joint replacement can prevent you requiring you to use a wheelchair or a walking stick. So, but the outcomes are different. So what do we do? We created this thing called QALYs, quality adjusted life years, to compare. Finally, cost benefit analysis. This one is trying to simplify it, convert everything into a cost and benefit into money terms. Unfortunately, it's difficult to value life or death in dollars. For example, we can look at what is the vaccination cost. Does the program savings prevent cost? This is something I'm quite interested in because a lot of times when we talk about cost savings, we're actually talking about cost avoidance. Remember, cost avoidance is not cost savings. Cost avoidance means you prevent one AMI, one stroke. But it doesn't mean that you save the money. What it means is that this patient don't comes to see you. And later on, when you talk about cost and revenue, it get a bit complicated because what costs the system is actually revenue to the hospital. Finally, how do I use which? For example, if you know the outcomes are equivalent, which is seldom the case, just focus on minimizing costs. This is a no-brainer. For example, to travel to, let's say you're in Singapore, you want to travel to Malaysia. If the outcome is the same, so you just choose the cheapest, whether it's economy class or is it cheaper airline? Because the outcome is the same. But then you may argue, oh, the service is different. I want first class or I want business class. Fine. So make this as part of your outcomes. But if the outcomes is just to travel to Malaysia, it's just to travel to USA, then that is your outcome. But if the outcome is comfort and you want to travel there, then maybe you may consider business class. So for the same business class, which is a cheaper airline. CEA, cost effectiveness analysis, if you're measuring specific clinical outcomes, this is usually done for single disease. Like for example, you want to prevent stroke, heart attack. Recently, I did one on sleep apnea. So this consider many different outcomes. For example, mortality, productivity gain, reduction of presenteeism, avoiding a motor vehicle accident. COA, this one is compare cross condition. So this one is a bit more challenging because we don't always have this data called QALYs. Usually, quality adjusted life years. Usually, it's through surveys, and so this is quite difficult to get. Increasingly, we're looking at patient-reported outcome measure, patient-reported experience measure. All these things you can actually try to normalize and standardize so that you can compare across condition. And finally, CBA, cost benefit analysis. This is for those program manager, CEOs, decision maker, because all they need to know is what is the cost, what is the money they will spend, and what is the money they need to recover. And a lot of times, we keep be aware that a lot of time cost avoidance is not cost savings. So you must look at really at cost savings. So at the end of the day, we talk about benefit. If you talk about the in terms of financial outcomes, it must either increase revenue, which means you have more patients, or the cost of treatment goes up. So the technology must help you to either have more patients or allow patients to pay more. And this must be balanced against cost. If not, can use the technology to reduce cost. If it doesn't increase the revenue, if it doesn't reduce cost, it will not give you any benefit in terms of money. Summary table. So cost minimization analysis look at cost only. CA cost effective analysis look at cost per clinical outcomes. And then cost utility analysis look at cost per QALYs. CBA focuses on using everything in money. So for those who are financially trained like me, with an MBA, we focus everything in terms of money. Reflection questions. So imagine you have a clinic. You must choose between a diabetes screening program versus a full vaccination campaign. How would you decide which evaluation type fits? To give some hints, if the aim in life is to increase financial performance, choose the one that will give you the most revenue, choose the one that will reduce the highest cost. So in this case, if diabetes screening program creates more patients to see you, and if the benefit goes to you, if you manage to capture the value, go for that. If the full vaccination campaign allows you to increase your revenue, at least in the short term, that is something that you want to choose. Okay, that is from the financial standpoint. But we are doctors, we are healthcare professionals, we have a bigger goal. So our bigger goal is to improve years of healthy lives, adding years of healthy life. In that case, we need to balance this between what the money comes. So some programs are done not because it makes money, some of them don't, but it's because it's for the real good. And if that's the case, and if it's not financially sound, feasible, we may need to rely on the government, the ministry, to help fund some of this. Or we can also involve Temasek Foundation, which is a philanthropy organization, to fund things that the government may not be keen to fund as now because there's not enough evidence. Thank you for listening.